वो स्क्रीन नहीं है यहाँ पे। चल पे। ठीक है। इसमें लैग है, उसमें लैग है, दोनों में से लैग किस में है? एक्चुअली एक दो दिन से हम लोग पिछली कुछ क्लासेस में मैं लेट ही रहा ना, तो इसलिए अभी लोग ज्वाइन करेंगे आराम से ना। आए हैं डॉक्टर साहब? बस ठीक है, देख लिया ना आपने उनको? जो भी है डॉक्टर प्रसन्न ही है ना? बस ठीक। ठीक है, पर जो भी आपसे मिलने आए हैं ना, मतलब ठीक ही होंगे, वही होंगे। ठीक है। हाँ हाँ बताइए। हाँ, उनको चाय वगैरह पूछ लेना बस एक बार। नहीं दादा, चाय और पानी। थैंक यू डॉक्टर पीस। डॉक्टर पीस, मे वी नो योर नेम प्लीज? हेलो चौधरी साहब, क्या हाल चाल? विक्रम जी, संजय जी, डॉक्टर प्रवीण जी, डॉक्टर अजय। नो, आई एम डूइंग गुड, आई एम डूइंग गुड, इट्स जस्ट दैट आई हैड सम कफ एंड कोल्ड। थैंक यू। भीम जी, पानी का ग्लास मिलेगा? थैंक यू जी। सेम हेयर डॉक्टर नवनीत जी। डॉक्टर मणिकांत जी, वेरी गुड, नॉट अ नाइस नेम। डॉक्टर अली जुल्फिकार जी, गुड इवनिंग, गुड इवनिंग, गुड इवनिंग। So yesterday, some of you were asking for GIT and hepatobiliary questions. So we'll be discussing those today. We'll be discussing those today. And today, incidentally, my son, my 11-year-old son, Jayaditya Bhagat, he's also watching my class. You know, is always asking me that, Dad, what does it take to become a doctor? मैं से बोलता हूँ कि भाई इसमें बड़ा दिमाग, बड़ी मेहनत लगती है, बड़ा ढंग से पढ़ना पड़ता है। सो ही इज ऑलवेज आस्किंग मी दैट, डैड देन हाउ कम यू बिकेम अ डॉक्टर? तो उसको लगता है कि सिर्फ उसकी माँ ही एक इंटेलिजेंट है जो डॉक्टर बन गई। बाप को तो कुछ समझते ही नहीं है बिल्कुल ये लोग। गुड इवनिंग जी। तो आज केवल अच्छी अच्छी बातें करेंगे बिकॉज ही इज वॉचिंग। तो उसके सामने केवल अच्छी अच्छी बातें करेंगे हम लोग, राइट? रास्ते में आते हुए मैं गुरदासमान साहब को सुन रहा था, तो उनका ये बोलना है कि दूध उबलते समय और बेटा बिगड़ते समय देर नहीं लगती। आज केवल अच्छी अच्छी बातें करेंगे। So Jay, now you are sure that your dad is also a doctor and your dad is also a teacher? उसको बिल्कुल विश्वास ही नहीं होता है, सीरियसली। पता नहीं डॉक्टर विक्रम क्या बनेगा, अभी तो उसकी हरकतें देख के लगता नहीं, डर लगता है उसकी हरकतें देख के, पता नहीं क्या ही बनेगा। Right. So without wasting the time, again it's a 2 hour session, and today we'll discuss the questions from GIT also. Today we'll discuss the question from hepatobiliary also. Right, and again the session will be mixed kind, like some part of it will be in Hindi, some part of it will be in English. Whatever I speak in Hindi, I'll definitely translate that to English also. Definitely I'll translate that to English also. Right. Now kindly try to answer this question. This question on your screen. I've got a very bad reputation of extending the class timing, but today the class will be crisp 2 hours, or maybe slightly even less than that. जैसे क्वेश्चन खत्म हम लोग क्लास खत्म कर देंगे, डोंट वरी। Yes, Dr. Praveen ji, Dr. Ajay Chaudhary gave the right answer. What is the needle? This needle is basically a J-shaped needle. J-shaped needle. So laparoscopic surgery, it is used for port closure. Fine. Laparoscopic incision closure needle. Incision closure needle. See, it has got a typical J shape. Typical J-shaped needle. We'll see some of the other needle designs also. Fine. So I have snipped it from some PPT presentation which was available on internet. So the different kind of needle. For example, straight needle will be used for a flat or the wound with a shallow depth. Shallow depth. Fine. 3/8 circle like this. Fine. Shallow depth of the skin wound. So general purpose needle basically is half circle needle. Half circle needle. Fine. General purpose needle. Fine. 5/8. If you extend it like this, if you extend the half circle needle, it will become 5/8 circle needle. 5/8 circle needle. Now this is also called as quarter circle needle. Quarter circle needle. So the different type of needle for the different type of wound, different type of uses, different type of uses, right? Now, again, another question on needle. Yes. No. No. This is a spatulated needle. This is also called as side cutting needle. Side cutting spatulated needle. Side cutting spatulated needle. So this is primarily used for ophthalmic surgeries. Ophthalmic surgeries. Now make sure when we are discussing this, you have to make sure that you know the different type of needles and their logos. Different type of needle and their logos. They're super important. Let me check up. I'll put all those things here. See here. This is important. The logos of different needles. Fine. I'll try to put it here. Maybe I can. Yeah, I can. Right. I gotta move it up slightly, otherwise हमारा अगला question visible नहीं होगा. Okay, I'll try to remove it and then we'll see over here only. We'll see it over here only. Fine. So you see taper point needle. Taper point needle. Now this is used for gentle cutting of the tissue. That means, let's say you are doing something on intestine, which happens to be a delicate tissue. Fine. In that case, the taper point needle. What is the symbol? Symbol of this needle happens to be a solid dot. Happens to be a solid dot. Blunt taper point needle. You see the symbol of this is a hollow dot. Hollow dot. Now this needle is used for friable tissue. This needle is used for friable tissue. Friable tissue like liver, like spleen. So you will be using blunt taper point needle and the symbol for this needle is a hollow dot. Fine. Cutting edge and reverse cutting edge. Now these needles are used for hard cornified tissue. Hard and cornified tissue. Now, what is the logo? For the conventional cutting, CC needle, conventional cutting needle, where the cutting edge is on inside, the logo is a triangle, straight triangle. Now, reverse cutting, where the cutting edge is on outside, the logo is an inverted triangle. Logo is an inverted triangle. Fine. Taper cut needle, again this is used for delicate tissue, used for ophthalmic surgeries also. Fine. Somewhere like small tissue, plastic surgery kind of tissue. Fine. So here the logo is a hollow dot with a Mercedes-Benz sign inside. Micro point spatulated curved needle, again this is used in ophthalmic surgeries. This is used in ophthalmic surgeries. Different type of needle. Again, you see, we've just seen the straight cutting needle, 1/4 circle needle, 3/8 circle, half circle, those kind of things. Fine. See here. Now, you see here, this is your 1/4 circle needle. 1/4 circle needle. Again, oh, I cannot see it. I mean, let me zoom it up a bit. See. So you see, this happens to be your 3/8 circle needle. 3/8 circle needle. 3/8 circle needle, half circle needle, 5/8 circle needle. 5/8 circle needle. Right? Okay. Then I'm sure you guys are aware about the different parts of a needle. See, this happens to be the tip of the needle. This happens to be the swag end of the needle, and the distance between tip and swag end of the needle. This is called chord. This is called chord. Now, E, this distance happens to be radius of the needle. The diameter of the needle happens to be thickness of the needle. Thickness of the needle. And this distance from swag end to the tip here, this distance is called length of the needle. Length of the needle. So make sure you are aware about the different components of the needle. Different components of the needle. Right? Let me show you. Maybe I've added some more of things like this. See, taper point needle, reverse cutting, conventional cutting, blunt and triangular pointed needle. See, taper point needle. Don't worry, there will be more of questions. Fine, just that 1-2 मिनट मुझे लगा कि ये पीपीटी बस आपको दिखा लूं, हल्की सी 2-4 इमेजेस ऐड किए थे. Fine. Conventional cutting, the cutting edge on inside. Fine. Reverse cutting, the cutting edge is on outside. Right? Yeah. So we move to the next question there, because we don't want to waste any of your time there. Let me just delete it. Just current, okay, instead. Okay. 45-year-old bus passenger was brought to surgery emergency. शायद क्वेश्चन कल डिस्कस कर लिया था हमने. After a road traffic accident, blood pressure is low and heart rate is also low, so your patient is suffering from neurogenic shock. ये गलती से क्वेश्चन आज ऐड हो गया, कल भी डिस्कस कर लिया था हमने. Now this question, ये कल क्वेश्चन मैंने छोड़ दिया था, आज इसको डिस्कस करते हैं. वो डॉक्टर साहब कल क्वेश्चन डिस्कस कर लिया था, इसलिए इसको दोबारा नहीं डिस्कस किया. I did not discuss it again. Yeah. Keep the legacy. क्या बात, क्या शानदार नाम भाई. बताइए जरा, ये क्वेश्चन चोरी किया कहीं से. 66-year-old women with a prolonged history of weakness and malaise was admitted to hospital because of chest pain, confusion, sweating, and severe dyspnea. Thank you, Dr. Paras ji. आपसे सीख रहे हैं. On examination, body temperature, blood pressure, pulse rate was so and so. So it was like low, blood pressure low, heart rate low. Fine. Respiratory rate is super high. Physical examination also revealed jugular venous distension, pulsus paradoxus, hepatomegaly, and diminished heart sound. Remember MDH. So what was there? Muffled heart sounds, distended neck veins. Fine. And then it was hypotension. Fine. Muffled heart sound, distended neck veins, and hypotension. Yes. So that is Beck's triad. What do we get to see? Pericardial effusion. We get to see pericardial effusion on the X-ray. Pericardial effusion on the X-ray. Right? Cardiac tamponade. Your patient is suffering from cardiac tamponade. Cardiac tamponade. Yes, that's a correct answer there. And what do we get to see on the X-ray? That is called as water bottle sign. Again, yesterday, few of you were asking for the PDF. So PDF, I wanted to share only after completing this. So today I'll share. Yeah, this is also called money bag sign. Money bag sign on X-ray. Right? Now, what happens there is something called as pulsus paradoxus. It is seen in cardiac tamponade. Now, what happens is at the time of inspiration, the right heart expands. So much more blood will enter the right heart. At the time of inspiration, too much blood will enter the right heart. Now, this blood will push the septum towards the side of ventricle. So, left ventricle, you see here, it has got very high volume, but on this side, the blood volume is very, very low. So, rather than increasing blood pressure, at the time of inspiration, the blood pressure will decrease. Now, this phenomenon is called pulsus paradoxus. This phenomenon is called pulsus paradoxus. Right? Now, this is seen in cardiac tamponade. This is seen in cardiac tamponade. Hanji. So, this 42-year-old female with a left breast mass undergoes left modified radical mastectomy. Remember what all is removed in modified radical mastectomy. We are going to remove breast, all the breast tissue. Fine. We are going to remove tumor. We are going to remove nipple. We are going to remove areola. Plus, we are going to remove level 1 and level 2 lymph nodes. If it is Auchincloss MRM. We are going to remove level 3 lymph node also. If it is Scanlon MRM. We are going to remove pectoralis minor also. If it is Pate's MRM. Fine. So, please tell what all we are going to remove here. Okay, sorry. Please tell the answer to this question. So, pathology reveals infiltrating ductal carcinoma. Remember what is the most common type? Infiltrating ductal carcinoma, NOS, not otherwise specified. Fine. Okay. Estrogen receptor status is negative. That means it is an aggressive cancer. Fine. What is the most appropriate adjuvant therapy for this patient? Now, that's a 3 centimeter tumor. Chemotherapy is must, but then that is not given in the options. Chemotherapy is not given in the options. What will we do? So, definitely for local control, we need to give external beam radiotherapy. External beam radiotherapy. Now, please, someone tell me the dose of radiation. Someone please tell me what is the dose of radiation given. Dr. Ahmed ji, Dr. Priyanka ji, Dr. Mimi, Dr. Bushra, Dr. Jishan, Sharia ji, Yashraj ji. Please tell me what is the dose of radiation given. Dose of radiation given. ना डॉक्टर साहब ये थोड़ा कम हो जाएगा. So dose of radiation conventionally it was 5000 centigrade. Now with the accelerated partial breast irradiation, now the dose is 3500 centigrade. Thank you ji. Thank you. 3500 centigrade, right? Doctor Sahab, pregnancy mein, that is the problem. Pregnancy mein we cannot give. See, remember what we discussed in pregnancy. Let's say the carcinoma. Dr. Ajay Chaudhary ka question hai ki carcinoma breast pregnancy mein kaise manage karenge. Remember we have a table. First trimester, second trimester, third trimester. So surgery basically can done in all trimester. In fact, in the late second trimester and the entire third trimester, we can also do breast conservation surgery. Remember, we speak about chemo cannot be done in first trimester, but we can do it in second and third trimester. If we talk about hormone therapy, if we talk about radiotherapy, that cannot be done in any trimester. That cannot be done in any trimester, right? Remember, when we speak about breast conservation surgery, so what are the contraindications there? Fine. And the first contraindication of the breast conservation surgery is pregnancy. Fine. Then positive tumor margins. Contraindication. You cannot do breast conservation surgery. You have to call the patient back and then remove her entire breast. Fine. Then positive tumor margin. Then prior history of radiotherapy. Prior history of radiotherapy. Prior history of radiotherapy. Now this is, like a controversial kind of question. I mean, this point is controversial. Prior history of radiotherapy. In the newer textbooks, they say that yes, you can do the breast conservation surgery. But in the classical teaching, prior history of radiotherapy is considered an absolute contraindication. Is considered an absolute contraindication. Polycentric tumors. Polycentric tumors means two or more than two tumors which are present in different quadrants. Remember, polyfocal tumor is a relative contraindication. Polyfocal means two or more than two tumors in same quadrant. Now this happens to be a relative contraindication, whereas polycentric tumors, where two or more than two tumors are present in different quadrants, now that happens to be an absolute contraindication. That happens to be an absolute contraindication. Right? So radiotherapy after the breast surgery. Now, so you see here, the next question comes up. A 4 weeks old baby girl is referred to surgery department with swelling of both legs, which the parents say has been present since birth. So the word is present since birth. Choose your answer very, very wisely. Now, Dr. Sahab, ध्यान से देखिए. Angioedema. How do you think it will be present? See, angioedema usually is located over face, neck, and that too over very, very small region. ना डॉक्टर साहब गलती कर गए ना. क्विकली जरा इसको रिवाइज करते हैं. फाइन. Quickly we'll revise the topic of lymphedema. Now, lymphedema. Remember what is the most common type? Most common type is secondary lymphedema. That means due to some condition. Fine. Now here, secondary lymphedema, most common cause in India and around the world. This happens to be filariasis. Right? And in the Western countries, this happens to be cancer related surgeries. Fine. Now, if we talk about primary lymphedema, that means there is no other condition. The only problem which your patient is facing is lymphedema, right? So there, the most common type is lymphedema precox. Now, lymphedema precox will appear anywhere between 1 to 35 years of life. It is not present since birth. Now, if the disease is running in families, it is called as Meiji disease. It is called as Meiji disease. Don't confuse it with Meige syndrome or Meiji syndrome. This is called as Meiji disease. Now, the second most common type of primary lymphedema is congenital. It is present since birth. It is present since birth. And if the disease is running in families, Dr. Saab, it is called as Milroy disease. Milroy disease. And then we have a third type, lymphedema tarda. Lymphedema tarda. See the word tarda. Tarda means slow. So this will develop somewhere after 35 years of life. Somewhere after 35 years of life. 35 years of life. So this is very slow to develop, very slow to develop, right? Remember, what are the clinical features? What are the clinical features? Your patient will have buffalo hump, where it is seen dorsum of feet. Fine. Your patient will have squaring of toes, right? And then your patient will have Kaposi, stammer sign. So there will be difficulty to pinch the skin on the dorsum of feet. Fine. Remember, in treatment, what is the common question asked? Diuretics are not helpful. Then what is the treatment? Compression and garments. Fine. Then we ask for the limb elevation. Ultimately, if we have to do surgery, then we have different treatment option like Nebulowitz operation, like Charles operation, like cis trunk operation, like Thompson operation. Fine. Lymphedema. So now when you know all this, now try to answer this question. Now try to answer this question. Because the lymphedema has been present since birth. So we'll say that probably it is Milroy disease. See, lymphedema precox will present anywhere between 1 to 35 years of age. Fine. Lymphedema tarda will present after 35 years of age. Fine. Hereditary angioedema most commonly would be present over the face. Most commonly, it would be present over the face, not anywhere else. Right? Okay. Can I just move it forward, please? Yes. So you see, a middle-aged lady, mother of 2 teenage sons, that means she has been pregnant at least twice. Lump in the region of her left groin. She was found to have soft, non-tender swelling on the medial side of her left thigh. Okay. The swelling was found to be below and lateral to pubic tubercle. Up till now, if you read only up to this point, so probably you might be thinking that your patient has femoral hernia. But the problem with femoral hernia is that very commonly it is strangulated. And if it is strangulated, it will not be non-tender. अगर आप इसके आगे पढ़ना शुरू करते हैं डॉक्टर साहब, तो फिर देखिए, she is found to have dilated veins in both her lower limbs. Now tell me the diagnosis. She is found to have dilated veins in her lower limb, both her lower limbs. Answer lies here. This is the key to the answer. Dilated vein in both her lower limbs. Dr. Saab, have you ever heard about the aneurysm of femoral artery? Rare things are actually rare. Rare things are rarely asked. So, if I have to exclude, this is the first option which I will exclude. Femoral hernia, okay, plus minus, right? Because, you know, if we read up to this point, यहाँ तक डॉक्टर साहब अगर पढ़ते हैं तो femoral hernia ही है. Fine. लेकिन आगे चलते हैं. Sliding hernia, certainly not. Fine. Saphenous varix. So your patient is having saphenous varix because if you read closely, your patient is suffering from varicose veins. Dilated, tortuous, elongated veins which are more than 3 millimeter in diameter. So saphenous varix is a swelling which is noted at saphenofemoral junction. Remember, saphenous vein is also called great saphenous vein because it's the longest vein of the body. Longest vein of the body. So saphenofemoral junction has got a swelling which is called as saphenous. If we read the yellow part, you will come to know that your patient is suffering from varicose veins. Middle-aged lady has been pregnant twice. Again, she has got every risk factor to develop varicose veins, right? So answer is D, saphenous. Oh, again the question is repeated. Again, these are like one-liner, mix and match kind of question, purely one-liner question. Yes, please. Okay, we'll check each one of them. Gluteal hernia arises from lesser sciatic foramen. Again, that's a question of anatomy, not the question of surgery. No. Sciatic hernia arises from greater sciatic foramen. No. Actually, they are crisscrossedly arranged. Crisscrossedly arranged. So, gluteal hernia will arise from greater sciatic foramen. Sciatic hernia will arise from lesser sciatic foramen. Right? Now, Spigelian hernia will arise through the linea semilunaris and paraumbilical hernia will arise through the linea alba. Remember what you see in paraumbilical hernia, you get to see the crescent sign. You get to see the crescent sign. So, which is the correct option here? 3, C. Fine. So, crescent sign is what you get to see in the paraumbilical hernia. And remember, paraumbilical hernia has high chances of strangulation. High chances of strangulation. We'll move forward. Again, which of the following are correctly matched? Which of the following are correctly matched? Now, this question, remember when we studied this question, many of you may be of the opinion that, yeah, this is a difficult question. Sir should not have asked this. Okay, I understand it's a difficult question. Fine. If you don't know the answer here, but if you know the correct answer of these are always taught in class. C and D, they're always taught in class. Maybe A and B are not taught in classes. Fine. But C and D are taught in class. If you know the correct answer here, you know the answer to the question. Same is true here. Yes, answer this question. कृष्ण सोनी जी, ओके। जब तक आप इस क्वेश्चन का आंसर देते हैं, मैं डॉक्टर कृष्ण जी का क्वेरी आंसर करने का कोशिश करता हूं। डॉक्टर साहब देखो, ये रहे रेक्टस एब्डोमिनिस मसल, ये रहा राइट साइड का, ये रहा लेफ्ट साइड का। यहां पे एक पॉइंट है डीप इंग्वाइनल रिंग, यहां पे एक पॉइंट है सुपरफिशियल इंग्वाइनल रिंग। अगर तो इंटेस्टाइन इधर से होती हुई ऐसे आई और फिर बाहर आई, कहां आई? स्क्रोटम पे, तब तो उसको बोलेंगे इनडायरेक्ट इंग्वाइनल हर्निया। कई बार क्या होता है, इंटेस्टाइन बोलती है कि भैया मुझे बाहर ही तो जाना है, तो मैं इस एरिया, ये जो येलो एरिया मैंने शेड किया, मैं सीधा इस एरिया को तोड़ के बाहर निकल लेती हूं। डायरेक्टली it will penetrate, it will puncture the muscle and come out. Now, what is this yellow area? This yellow area is called Hazelback triangle. डायरेक्ट हर्निया, इंटेस्टाइन ने डायरेक्टली मसल को तोड़ा और बाहर निकल आई। फाइन। अब इंसिडेंटली होता क्या है कि यहां पे एक आर्टरी है, क्या नाम है उस आर्टरी का? इंफीरियर एपिगैस्ट्रिक आर्टरी। तो अगर हर्निया इसके लेटरल निकला तो इनडायरेक्ट इंग्वाइनल हर्निया, अगर इसके मीडियल निकला तो डायरेक्ट इंग्वाइनल हर्निया। इनडायरेक्ट और डायरेक्ट, देखो डायरेक्ट इंग्वाइनल हर्निया मसल्स को तोड़ के निकला है, तो मेरे और आपके जवान लोगों के, जवानी बड़ी है क्या करें, मेरे और आपके जवान लोगों के मसल को तो तोड़ नहीं पाएगा हर्निया, बूढ़े लोगों के मसल को तोड़ देगा। तो डायरेक्ट हर्निया इज कॉमन इन एल्डरली, डायरेक्ट हर्निया इज कॉमन इन एल्डरली। बाय गॉड, अपने आप को जवान कह के मजा आ जाता थोड़ा सा। लेट्स सी द आंसर। Hernia through the Gimbernat ligament is a lodgier hernia. Lodgier hernia, remember, it is a type of femoral hernia. It is a type of femoral hernia. Hernia containing omentum is called epiplocele. It is correct. देखो, hernia containing intestine is called enterocele. Is called enterocele. Hernia containing vermiform appendix is called ami and hernia. Is called ami and hernia. Hernia containing Meckel's diverticulum is called Litter's hernia. Is called Litter's hernia. Fine, is called Litter's hernia. So A and B are correct. Litter hernia. See, one of the book has mentioned litter word also. It is Little's hernia, but one of the book has mentioned litter also. Nevertheless, C option is definitely not correct. So A and B, they are correct. They are correct option. Fine, A and B are correct. Lodgier hernia is a type of femoral hernia. Now, we all know, एक मिनट डॉक्टर साहब, अगर आप थोड़ी सी पेशेंस बनाए रखें, मेरे को हर बार लगता है कि क्लास लंबी ना खिंचे, बट अगर आपके मन में कोई भी क्वेरी रहेगी तो वो भी अच्छी बात नहीं है। बस फटाफट से आई जस्ट शो यू। अभी देखो, डॉक्टर कृष्ण ने जो क्वेरी पूछा, अगर इंटेस्टाइन इस पॉइंट से तोड़ के सीधी बाहर निकल जाए तो डायरेक्ट इंग्वाइनल हर्निया। अगर इंटेस्टाइन अपना सही रास्ता फॉलो करे, पहले डीप रिंग में जाए, फिर इंग्वाइनल कैनाल में, फिर सुपरफिशियल कैनाल में, तब वो क्या कहलाएगी? तब वो हर्निया क्या कहलाएगा? इनडायरेक्ट इंग्वाइनल हर्निया। फाइन, ये क्या है? इंफीरियर एपिगैस्ट्रिक आर्टरी। फाइन, अगर इसके मीडियल साइड पे है तो डायरेक्ट, लेटरल साइड पे है तो इनडायरेक्ट। राइट, देखो जी, इनडायरेक्ट, डायरेक्ट। डॉक्टर कृष्ण जी इसको देखिएगा जरा, इफ यू कैन टेक अ स्क्रीनशॉट, इफ यू कैन क्लिक अ पिक्चर, तो इसको पढ़ेंगे और देन इफ यू हैव द क्वेरी यू कैन ऑलवेज सेंड द क्वेरी टू मी। राइट, बस एक मिनट, आपको अलग अलग तरह के फेमोरल हर्नियाज दिखा लें, फिर आगे चलते हैं। See here, the different type of hernia, different type of hernia, अलग अलग तरह के hernia, अलग अलग तरह के femoral hernia. Now what is the problem with this hernia? You know, this the hernia which we just asked, lodgier hernia. Lodgier hernia is always strangulated. Femoral hernia में high chances है strangulation के, but one type of femoral hernia called lodgier hernia is always strangulated, is always strangulated. Fine, बहुत super high chances strangulation के. Fine, so A and B are correctly matched, C is not correctly matched. Different type of hernia. Again, ये भी हल्का सा डिफिकल्ट क्वेश्चन मान सकते हैं इसको, हल्का सा डिफिकल्ट क्वेश्चन। आप कर पाए तो ठीक है, नहीं कर पाए तो वी कैन स्किप। देखो, प्रोट्रूजन ऑफ प्रीवेसिकल फैट एंड पार्ट ऑफ ब्लैडर, बेसिकली कोई भी एक्स्ट्रा पेरिटोनियल ऑर्गन अगर बाहर आने की जिद करे, if any extra peritoneal organ is herniating out, we say that it is a sliding hernia. We say, I understand that थोड़ा सा difficult question है डॉक्टर साहब। Presence of sac under fascia covering the pectineus muscle is Cloquet hernia. And third, large red trophic ulcer is called inflamed hernia. थोड़ा difficult question था, छोड़ दिया, इसीलिए छोड़ दिया। So all are correct, all are correct. All are correct. All are correct. Right? थोड़ा डिफिकल्ट था, आई अंडरस्टैंड, इसलिए छोड़ रहे हैं क्वेश्चन को। ये क्वेश्चन इजी है, बताइए। very easy question from the topic of urology. इससे easy question नहीं हो सकता. So if you read the language of the question, your patient is having painless hematuria. Your patient is having painless hematuria. So painless hematuria is seen in bladder carcinoma, is seen in bladder carcinoma. Cystitis, if you want to read the scenario based question on cystitis, there would be suprapubic pain. Fine. There would be increased frequency of micturition. Diverticulitis. Fine. So if your patient has diverticulitis, again there would be severe pain. There would be fever with rigor and chills. Renal calculi, remember there would be colicky pain. There would be colicky pain. Yes. So considering the age of the patient, naturally would like to go in for bladder carcinoma as the treatment. It's not child, it's chills. I'm sorry. Yeah. 8-year-old boy, emergency department, 3-day history of flank pain, abdomen pain, fever, reduced appetite. Minimal left side flank pain and lower abdomen tenderness. Fluctuant, non-tender swelling in the child's groin. So there is a groin swelling. There is a groin swelling. There is pain. There is fever. And most important, there is reduced appetite. You note that child is walking with the limp. And there is pain in the hip on straight leg raising against resistance. Okay, answer is correct. Answer is correct. But tell me, what is the diagnosis? Answer is correct. But what is the diagnosis? Diagnosis is that it is an abscess. सब लोगों ने वो जोक सुना होगा, कार नहीं मारुति कार. It is an abscess. But कौन सा abscess? So if you note down, it is a classical case of psoas abscess. Classical case of psoas abscess, which generally occurs in tuberculosis. Generally occurs in tuberculosis. Generally occurs in tuberculosis. Right? With this, we move to the next question. 52-year-old man presents to general practitioner complaining of enlarging lump on his face, 1 centimeter, pigmented raised lesion. ये तो कल भी पढ़ा था हमने. Shiny rolled edge, it is a basal cell carcinoma. छोड़ते हैं इसको. Basal cell carcinoma. 52-year-old. ये कल वाली तो नहीं खुल गई. Having noticed a crater-like lesion on the sole of her right foot. Type 2 diabetes mellitus would cause neuropathy. Would cause neuropathy. Fine. So your patient is having neuropathic ulcer. Remember, the most common site is heel. Most common site is heel. Fine. Most common site is heel. A 18-year-old has been physically assaulted outside a bar. She appears drowsy and there is gross swelling on the right side of the face. She is making groaning sounds. So that means EVM. But is verbally interactive. But is not verbally interactive. Okay. She is unable to obey commands but withdraws to pain. That means flexion. Now, eye signs. She is not opening eyes spontaneously, not to sound. That means E is 2. Fine. Verbal. She is just making some sounds. Just making some sounds. If, verbal. Talking coherently, 5. Confused, 4. Fine. Words, 3. Just making some sounds, 2. And on the motor point, what is she? Obeying commands. And she is just doing flexion. So, the final score comes out to be 8, GCS. Again, that's a practice because we had discussed this topic yesterday. We'll move forward. ये भी पढ़ लिया. क्या हो रहा है? Okay. 50-year-old woman has been hit by a car and thrown 5 meters away. Loss of consciousness. Brought by ambulance, immobilized. She is alert, oriented, and talking happily. Within a few minutes, she starts to deteriorate rapidly and hence becomes unconscious with a GCS score of 5. Hanji, what is the answer here? See, GCS less than 8 is not only the indication of endotracheal intubation, it is considered to be most common indication. It is considered to be most common indication of intubation. Most common indication of intubation. Fine. So probably what has happened to the female extradural hematoma? Extradural hematoma. Because remember, she was talking rapidly. That means there is a lucid interval. There is a lucid interval. Can any one of you please tell me, lucid interval is present only in extradural hematoma or some other hematoma also? Lucid interval may be present in subdural hematoma also. Subdural hematoma also. When the subdural hematoma may become so big, it may cause problem. It may cause problem. In rare cases, it may be present in subdural hematoma also. Hanji. Read it. 46-year-old male underwent routine annual examination. That means your patient had no problem at all, no clinical feature, and a swelling was noticed in the right testis. Swelling was described as bunch of grapes by the examining general practitioner. Whenever I talk of surgery, you people always start talking about gynecology. Bunch of grape finding you see in the H mole. I know that. Fine. But here tell me, where will you see bunch of grapes? ना डॉक्टर साहब यही तो बात फंस गई. Epididymal cyst. Epididymal cyst. Epididymal cyst. फिर से वही कल वाला. It will be seen in epididymal cyst. See, epididymal cyst has clear fluid, absolutely clear fluid. Fine, epididymal cyst. Now this will give rise to bunch of grape finding. Now if you pass light through it, brilliantly transilluminant, Now this will give rise to Chinese lantern pattern. Chinese lantern pattern. देखते हैं डॉक्टर साहब, A and C भी देखते हैं. Fine. Chinese lantern pattern because it is brilliantly transilluminant. Fine. Now, spermatocele, it will contain sperms. It will cause some discomfort. Fertility is not affected. Now this has barley water fluid. That means unclear, opaque kind of fluid. Opaque kind of fluid. Now, hydrocele of the cord, it will be located in the spermatic cord. Fine. And not over the testis. See, it clearly says, the language of the questions clearly says that it was noticed in the right testis, not over the spermatic cord. And here, what do you get to see? You get to see beaded like this. Beaded vas and beaded epididymis. Right? चौधरी साहब ये क्या बना के भेजा? एक ग्लास जैसा लग रहा है कुछ. हाँ जी, इस क्वेश्चन का आंसर दीजिए. जीआईटी स्टार्टिंग. जीआईटी स्टार्टिंग. अच्छा. हाँ जी, इस क्वेश्चन का आंसर दीजिए प्लीज. आई होप यू ऑल कैन रीड दिस क्वेश्चन. इफ यू वांट मी टू जूम इन, आई कैन. "23-year-old aesthetically built, पतला सा, बहुत पतला सा, inmate of a de-addiction center is being evaluated for the symptom of postprandial after meals, epigastric pain, fullness, nausea, and vomiting. His physical examination is unremarkable except that he is very thin." Okay. No abdominal sign. Barium GI series show dilated duodenum and stomach with minimal flow into jejunum. Which of the following is operative management of choice for this patient's condition? डॉक्टर साहब पहले डायग्नोसिस फिर आंसर. डॉक्टर एसवी क्रिएशन जी. अरे सब लोग बी क्यों आंसर दे रहे हो यार? 23 साल का आदमी है, क्या सोच लिया आपने? क्या डायग्नोसिस है? हाँ, अब डॉक्टर साहिल ने सही आंसर दिया और देके डिलीट कर दिया. पहले मुझे डायग्नोसिस बताइए फटाफट से. कल से आप जीआईटी जीआईटी कर रहे थे, जीआईटी वाला क्वेश्चन आया तो आंसर छुपा रहे हैं. याद कीजिए, योर पेशेंट इज सफरिंग फ्रॉम Wilkie's syndrome. Wilkie's syndrome. Compression of third part of the duodenum. Now this occurs in rapid weight loss. This occurs if your patient is wearing tight garments. If your patient is wearing tight garments. See, this is Wilkie syndrome. Compression of third part of the duodenum. Compression of third part of the duodenum. Fine. Third part of the duodenum by the superior mesenteric artery. Third part of the duodenum by the superior mesenteric artery and aorta. Superior mesenteric artery and aorta. उसके बीच में दब गई. See, superior mesenteric artery and aorta will compress the duodenum. Will compress the duodenum. Fine. Will compress the duodenum. So, what is the treatment of the condition? Treatment of the condition is duodenojejunostomy or duodenostomy. Duodenostomy. Fine. Duodenostomy. Wilkie's syndrome. Remember, Wilkie's syndrome is common in the female who wear a particular type of dress called corset. Corset. Right? Wilkie's syndrome. ये थोड़ा इजी क्वेश्चन आ गया. 35-year-old male noticed bleeding per rectum. Remember, what is the most common cause of bleeding per rectum? It is hemorrhoids. Remember, what is the most common cause of massive bleeding per rectum? It is diverticular disease. I'm sorry. It is diverticular disease. Remember, what is the second most common cause? It is angiodysplasia. Now give me the answer. So what basically are you doing? You are doing injection sclerotherapy. You are trying to inject phenol in almond oil by, what is the name of the syringe? Gabriel syringe. By Gabriel syringe. Let's see, what does a Gabriel syringe look like? What does a Gabriel syringe look like? See, this is what the Gabriel syringe looks like. Gabriel syringe. पुराने ज़माने की syringe, like this. Gabriel syringe. This is how the Gabriel syringe looks like. Gabriel syringe will look like this. Fine. I don't know whether I can put it here or not. Yes, I can put it here. Gabriel syringe. Fine. So here the treatment is injection sclerotherapy. I was born and brought up in a small city. तो छोटे शहरों में याद करो, जगह जगह पोस्टर लगे होते हैं, बवासीर एक टीके में जड़ से खत्म. ये वही टीका है. Fine. Injection sclerotherapy. Grade 2. What is the treatment? Treatment is baron bending. Baron bending. हाँ, बसों पे भी लगा होता है. Grade 3 and 4. Remember, we have different surgeries. Milligan-Morgan operation, Ferguson operation, Longo's operation. Fine. So bending is used for grade 2 hemorrhoids. Since I've shown you the picture of injection sclerotherapy, so most likely it would be grade 1 hemorrhoid. Most likely it would be grade 1 hemorrhoids. Grade 1 hemorrhoids, right? We'll move forward. Again, that's a slightly difficult question, not from surgery, but from pathology. 30-year-old male with a history of Crohn's disease with several extra-intestinal manifestations presented to surgery emergency with complaint of right lower quadrant pain and obstipation. Obstipation, not being able to pass flatus or fecal matter. That means there is intestinal obstruction. Is found to have segment of thickened ileum causing obstruction. Surgery was performed and affected segment had to be removed. That means whatever the disease was, आपने उसको निकाल दिया. You removed it. Now, which of the extra intestinal manifestation are likely to improve? Erythema nodosum improves. These don't improve. Ankylosing spondylitis and sclerosing cholangitis, they don't improve. Yes, Dr. Saab. So this is the only problem that will improve. They will not improve. They will not improve. The idea of this question was to compare Crohn's disease and ulcerative colitis. Remember, Crohn's disease, transmural. That means all the layers will be involved. Only mucosa and submucosa. Crohn's disease, skip areas. Ulcerative colitis, continuous involvement. Crohn's disease, more chances of fistula, more chances of obstruction. Ulcerative colitis, more chances of cancer, more chances of cancer. That is the main difference between Crohn's disease and ulcerative colitis. Ulcerative colitis. हाँ जी डॉक्टर साहब, हाँ जी, आज मैं पीडीएफ भेजूंगा, डोंट वरी. Yes. 7-year-old child was brought to surgery emergency with complaint of bleeding per rectum. Technetium scan was done which confirmed the presence of bleeding from Meckel's diverticulum. Remember Meckel's diverticulum, the rule of 2. Rule of 2, that means it is 2 inches long, 2 feet from the ileocolic junction. One thing, fine. Two type of mucosa, gastric and pancreatic. What is the other two? Other two is half of the symptomatic patients are less than 2 years of age. So that means children, most common clinical feature is bleeding. Adults, most common clinical feature is pain due to intussusception. Okay. Now, what is the management? What is the management? You will have to cut that part of ileum which has got Meckel's diverticulum. That is the only treatment. That is the only treatment. A 40-year-old man is admitted to hospital with severe abdominal pain. Man, okay, he is conscious but anxious. Blood pressure 90/60, pulse rate high, respiratory rate high. So let's write here, heart rate high, blood pressure low, respiratory rate high. On examination, board-like rigidity, guarding and rebound tenderness. That means patient has peritonitis. Now this peritonitis can be biliary peritonitis, bile leakage has occurred. This can occur due to perforation of stomach or intestine. Initiation of fluid resuscitation was done. What diagnostic study is most optimal to proceed and establish a working diagnosis? See, first of all, you'll get to see upright chest X-ray. This is quick, easy, safe, can be done bedside, and what it will show, remember, it will show air under diaphragm. Now CT scan, this is, let's say, the definitive investigation, but it requires contrast media. You need to send the patient to radiology department. Fine. So this, you just need a working diagnosis. Fine. So this is better choice. This you can say as the second choice. So answer is 1. Your patient is having peritonitis, right? So I'll go with the first one, that is the upright chest X-ray. Upright chest X-ray will show you air under diaphragm. Fine. So you will get the working diagnosis in 2 minutes. Right? If, see, your patient is having pain abdomen, peritonitis, it could only be because of 2 things. One is bile leakage, no chances. Second is that probably there has been peptic ulcer perforation. Just get an X-ray done on the bedside and you will immediately get the diagnosis. 52-year-old underwent surgery for duodenal ulcer disease. Hospital stay was uneventful. Shortly after starting normal diet, patient developed severe diarrhea with as much as 15 bowel movements per day. Medication offered little relief. gastrographin swallow. Gastrographin, water soluble contrast. See, that can be done, but when you have a bedside investigation available, why do you want to go in for other investigation? Truncal vagotomy. So, truncal vagotomy, known complication of truncal vagotomy is fulminant diarrhea. Fulminant diarrhea, massive diarrhea is a known complication of truncal vagotomy. Massive diarrhea is a known complication of truncal vagotomy. Yes. Pathognomic of the condition. Before I ask you this question, let me tell you, buddies, that this is common bile duct. This is main pancreatic duct. This is main pancreatic duct. Now, please tell me, see this. Oh, there is pixelation. So let me just give you a hint that this patient, okay, is suffering from chronic pancreatitis. And what you get to see over here is chain of lakes appearance. Chain of lakes appearance. Chain of lakes appearance. Fine. So what is the pathognomic of chronic pancreatitis? Now the question is a one-liner. Now the question is a one-liner. What is pathognomic of chronic pancreatitis? What is pathognomic of chronic pancreatitis? It is the fibrosis. It is the fibrosis. Pain. Remember, it is the most common clinical feature. Pain is the most common clinical feature. Fibrosis is considered pathognomic. Is considered pathognomic. Okay. Which fecal test is considered slightly specific? So you will check for fecal elastase content. Fecal elastase content. अभी आएगी डॉक्टर साहब, अभी आएंगी. First, give me an answer to this question. 38-year-old alcoholic presents with epigastric pain radiating to the back. Radiating to the back. Calcification can occur, but fibrosis will occur much early. Exactly, Dr. Rohanji. Your patient is suffering from pancreatitis. Your patient is suffering from pancreatitis. Your patient is suffering from pancreatitis. See, kidney, spleen, liver. Fine. So this organ naturally is pancreas. See, the pancreas body, pancreas tail. Now, see, this is chronic pancreatitis with calcification. Now, please tell me, 37-year-old patient has presented with SIRS, systemic inflammatory response syndrome. What do you get to see? What is the diagnosis? You get to see something very, very typical. Anyone? So you get to see perirenal halo. Where do you get to see perirenal halo? You get to see it in pancreatitis. You get to see this in pancreatitis. Perirenal halo. Why? Because fat around the kidney is digested. Fat around the kidney is digested. Now, the idea was to give you hint about the systemic inflammatory response syndrome. See, you must be aware about the diagnosis. What is the diagnosis of sepsis now? Sepsis definition is life-threatening organ dysfunction due to dysregulated response to infection. Organ dysfunction we measure with the help of quick SOFA. We measure it with the help of quick SOFA. Sequential organ failure assessment. So if the respiratory rate is more than or equal to 22, if the altered mental status is there, if the systolic blood pressure is less than or equal to 100 millimeter of mercury, if any two of them are present, we say that patient is deteriorating rapidly. But what about the systemic inflammatory response syndrome? If the temperature, this is very important, temperature less than 36 or more than 38, heart rate more than 90, respiratory rate more than 20, your patient has leukopenia or your patient has leukocytosis, or your patient has 10% band cells, that means new neutrophils, right? So we say that your patient is having systemic inflammatory response syndrome. 24-year-old female with pain, nausea and anorexia. Remember, pain, fever, nausea, vomiting, anorexia. Now this is called Murphy triad. Now this is present in appendicitis. Don't confuse it with Murphy sign, which is present in cholecystitis. Exactly, Dr. Clark ji. Your patient is suffering from appendicitis. 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 ये डॉक्टर तन्मय जी, डॉक्टर तन्मय बेटे आपने आंसर दिया that patient is suffering from appendicitis. Please tell me about the position of appendix, tip of the appendix. कोई बताएगा मुझे कि tip of the appendix कौन सी पोजीशन पे है, कौन सी पोजीशन पे? डॉक्टर साहब एसवी क्रिएशन साहब इसमें देखो, pelvic position, it is lying in pelvic position, it is lying in pelvic position. याद कीजिए, tip of the position, tip of the appendix, retrocecal most common, pelvic second most common. Now pelvic appendicitis has delayed diagnosis, most delayed diagnosis. Fine. Now post-ileal, remember it is the least common position, least common position. We are talking about tip. Base of appendix is fixed. Where do you get to see? At the end of anterior tinea coli. You got to see at the end of anterior tinea coli. Right? Now, the common bacteria Bacteroides, fragilis, and E. coli, right? It is common in young, 10 to 30 years of age. Now, that's a very typical finding. Very typical finding. Double contrast barium meal. This is what you get to see in stomach. Double contrast mean first you injected barium, then you injected some air. Then you injected some air. Kya baat. So that is a typical appearance of peptic ulcer. So there will be a central core and then there will be radiation. Then there will be radiation like this. A central core and then there are multiple radiations. Multiple radiations. Typical appearance of peptic ulcer. Very good answer. Very, very good answer. See here, there will be a central core and then there would be radiation. There would be radiations coming on all sides, right? Very good answer. Now that's an extremely easy question. Extremely easy question. So your patient, 42-year-old female, presented with right upper quadrant pain. Kya baat. So that happens to be a gallbladder stone, and what you are seeing here is posterior acoustic shadow. You are seeing posterior acoustic shadow. What else do you get to see? Mercedes Benz sign. You also get to see seagull sign. Seagull sign. Very good answer. What do you get to see over here? So you get to see multiple posterior acoustic shadows. Multiple posterior acoustic shadows. Now this. CT scan of a 55-year-old alcoholic male. 55-year-old alcoholic and male. First keyword, second keyword, third keyword. See this. So buddies, this is pus, and around the pus you can see edema. Around the pus you can see edema. So this is a pyogenic liver abscess. Pyogenic liver abscess. How can I say that it is a pyogenic liver abscess? Let us quickly compare both. Pyogenic liver abscess, amoebic liver abscess. Both are common in males. Pyogenic liver abscess, 50 to 55 years. Amoebic liver abscess, 20 to 40 years. 20 to 40 years. Fine. Common in alcoholics. Common in alcoholics. Right? Amoebic pyogenic liver abscess, most common clinical feature fever. Amoebic liver abscess, most common clinical feature is pain. Most common lab anomaly is alkaline phosphatase. Here the common lab anomaly is prothrombin. Jaundice is present in 25%. Jaundice is present only in 5%. 50% cases have multiple abscess. Only 20% cases have multiple abscess. Treatment is antibiotics plus drainage. Pigtail catheter. Amoebic liver abscess, treatment is metronidazole. Treatment is metronidazole. So what do you get to see over here? This is called as double target sign. That means pus surrounded by edema. Pus surrounded by edema. So your patient is having pyogenic liver abscess. Pyogenic liver abscess. Fine. Remember what is the most common organism. Please tell what is the most common organism. It will be Klebsiella in India. It will be Klebsiella in India. World over, it may be E. coli, but in India, it is the Klebsiella. Now, what do you get to see? You get to see cluster sign. This is also seen in pyogenic liver abscess. You get to see multiple abscess cavity, multiple abscess cavity, multiple abscess cavity, cluster sign. This is also seen in pyogenic liver abscess, pyogenic liver abscess. See, cluster sign. 50% of the cases of pyogenic liver abscess are multiple. See, what you get to see is the typical target sign. Pus surrounded by edema. Pus surrounded by edema. Yes. So your patient, 48-year-old female, native of Eastern India, clinical feature, hepatomegaly, आशीष चौधरी जी, आप हैं डॉक्टर साहब? आप क्लिनिकल क्वेश्चन पूछते हैं, मतलब क्लिनिकल इंफॉर्मेशन मांगते हैं, बताइए क्या दिख रहा है इसमें? Yes, hydrated cyst. Most common sign is hepatomegaly. Most common clinical feature is dull ache. So what you get to see over here is typically called honeycomb appearance, also called as wheel spoke wheel, roseate appearance, racemose appearance. Remember the common question they ask in microbiology, what is the definitive host? Carnivorous animal, dog. Fine. Okay, then what is the intermediate host? Intermediate host is a herbivorous animal, sheep. Humans are accidental, dead end host. What is the causative organism? Echinococcus granulosus. Now, there is something called as malignant hydatid. Now, this would be caused by Echinococcus multilocularis. Right? Now, you got to see this. So that's a very, very typical appearance. Esophagus, very typical appearance of esophagus. Dr. Manisha Bete, exactly. So we call it as shaggy esophagus. Which is caused by Candida. Shaggy esophagus. Now this is the endoscopic appearance of shaggy esophagus, right? So when we were in college, this guy was too famous, shaggy bombastic. Yeah. 32-year-old female presents to surgery emergency with complaints of pain. Right hypochondrium. So your patient has pain, right hypochondrium of less than 24-hour duration. Okay. She's clinically febrile. So your patient has fever. Your patient has high TLC, slightly high, LFTs normal, Ultrasound reveals gallstone with pericholecystic fluid. The diagnosis is settled. Your patient has acute cholecystitis. Preferred management. यार एक क्या करते हो, जानबूझ के मजे लेते हो क्या? डॉक्टर सारिका जी, डॉक्टर राजेश जी, डॉक्टर शबीर जी. Patient has presented within 24 to 48 hours. You will do laparoscopic cholecystectomy. If the patient comes to you after 48 hours, you will do interval cholecystectomy. Interval cholecystectomy. That means you will give your patient IV fluid, antibiotics, and then you will do cholecystectomy after 6 to 8 weeks. यहां पे आपका पेशेंट 10 घंटे के अंदर अंदर ही आपके सामने मौजूद था. डॉक्टर साहब करेंगे, रिससिटेशन करेंगे, लेकिन आप ये चौथी ऑप्शन देखो, इसमें cholecystectomy कर रहे हैं 8 हफ्ते के बाद. We are doing cholecystectomy after 8 weeks. Not correct. You have to do cholecystectomy immediately. You will do resuscitation, definitely you will do. So here, if your patient has just gallstones, cholelithiasis, your patient has pericholecystic fluid also, that means acute cholecystitis. What is the treatment? Laparoscopic cholecystectomy if the patient presents within 24 to 48 hours. You will do resuscitation, but then that option is not there in our options. So treatment is immediate laparoscopic cholecystectomy. This you will do when the patient presents after 48 hours of the onset of pain. Watch this. The question is on next slide. Okay, I'll ask you the question here. Question is, what is the investigation of choice? Whether it is ultrasound or it is contrast CT or it is barium or is it MRCP? Yes, exactly, Dr. Navneet ji. Your patient is having pancreas devisum. That means failure of fusion of the buds of failure of fusion of the ducts of pancreas. Most common congenital anomaly. Any problem with the duct, investigation of choice will always be MRCP. Any problem with the bile duct, any problem with the pancreatic duct, investigation of choice will always be MRCP, right? So your patient has pancreas devisum, so treatment or investigation of choice will be MRCP. Generally, this condition remains asymptomatic. If it is becoming symptomatic, your patient will develop pancreatitis. In that case, the treatment option is papillotomy. Read the question. Elderly female. So first hint is age. Paresthesia. Dyspepsia. Neurological examination, loss of, that means you read that your patient has multiple neuropathies. Okay, vitamin B12 levels are low. Low B12 levels, that means your patient has pernicious anemia. Remember, pernicious anemia is a risk factor of cancer of the stomach. Risk factor of the cancer of the stomach. Upper GI endoscopy reveals an ulcer in the stomach. Okay. She has been taking COX-2 inhibitors. Remember, COX-2 inhibitors. Valdecoxib, Paracoxib. Now they are not used anymore. What is used? Etoricoxib. Why are COX-2 inhibitor used? Because they don't cause any problem in the stomach. They don't cause any problem in the stomach. Diclofenac is a COX-1 inhibitor. Fine. So it is not a peptic ulcer because it is not causing any specific gastric symptom. So it is not a peptic ulcer. It is not a gastrointestinal stomal tumor. See, gastrointestinal stomal tumor is present here, deep inside the body. But here, if you read the language, your patient has an ulcer. So that means it is a carcinoma of the stomach. Remember, carcinoma of the stomach will present with neuropathies, will present with pernicious anemia. Pernicious anemia is a risk factor. NSAID-induced ulcer. COX-1 inhibitor like diclofenac will cause ulcer. COX-2 inhibitors don't cause ulcer. COX-2 inhibitors don't cause ulcer. Right? अब जरा फटाफट से let's see the stomach very quickly. I totally understand my time limitations. Remember, males, they have got special problems. Yesterday it was International Men's Day and yesterday it was International Toilet Day also. मतलब कोई इज्जत ही नहीं है बिल्कुल. Right? Now males, carcinoma stomach is much more common in males. If there is family history, smoked food, familial polyposis, hereditary non-polyposis, atrophic gastritis, intestinal metaplasia, tobacco use, Menterier disease. These are the risk factor. These are the risk factors for carcinoma stomach. Carcinoma stomach. Fine. Alcohol, smoking, H. pylori. These are all the risk factor. All the risk factors. Fine. Now, so the different paraneoplastic symptoms which you may be seeing, lesser Teralt sign, multiple seborrheic keratosis, acanthosis nigricans, darkening in the axilla, darkening in the neck, acanthosis nigricans, Sister Mary Joseph nodule around the umbilicus, Bloomer shelf nodule, recto vesical pouch. Fine. So different, these are the different clinical features which you will get to see in carcinoma of the stomach. In carcinoma of the stomach. Dr. Manisha, I got your point. I got your point. 59-year-old female with a long history of constipation. So this is the risk factor. 4-month history of episodic left-sided abdominal pain relieved by defecation. Now, my idea is to help you understand that few typical clinical histories. Now, अगर आपको ये हिस्ट्री देखने को मिली, लेफ्ट साइडेड abdominal pain relieved by defecation, relieved by defecation. So it is the typical clinical history of diverticular disease. Typical history of diverticular disease. Pain, left side relieved by defecation. कोई और आंसर नहीं. Diverticular disease. Remember, apple core lesion you will get to see in carcinoma. Bird beak appearance you will see in valvulus. Diverticular outpouching you will get to see saw tooth appearance on barium enema. Non-filling of the appendix you will see in appendicitis. You will see that in appendicitis. Yes, in diverticulitis it is contraindicated. See, Dr. Saab, ध्यान से देखिए जरा. Your patient, you have to see. Doctor कौन है हमारे? Dr. Manisha जी. Dr. Manisha, beta, see. You have to see the difference in the names. Diverticulosis just means your patient has multiple diverticulae. Diverticular disease, that means your patient has multiple diverticulae plus symptoms. Fine, symptoms. Diverticulitis means your patient has diverticulae plus inflammation. Diverticulae plus inflammation. So yes, barium may be contraindicated in diverticulitis, but in diverticular disease, diverticulosis, it is the investigation of choice. Double contrast barium enema is the investigation of choice. Dr. Manisha, I hope I could answer your query. Okay, so then tell me, what is the investigation of choice in diverticulitis? It is contrast CT. Let me tell you. Contrast CT. 34-year-old man with a 6-month history of pain in the rectum. Pain in the rectum. Now again, this is very typical. Intermittent pain in the rectum which is unrelated to stools. Pain in the rectum which is unrelated to stools. Pain occurs at night. Very typical history. जिन्होंने पढ़ा हुआ है 10 सेकंड में आंसर देंगे इसका. No mucus, no blood. Digital rectal examination is unremarkable. So this is a vague condition called proctalgia fugax. Okay, मान लिया कि आपने proctalgia fugax नहीं पढ़ा हुआ. But anal fissure, what will you get to see? Cano-shaped ulcer. Anal fistula, what will you get to see? Discharging sinus. Perianal abscess, you will get to see bulge, which is extremely tender. So your patient is suffering from a vague condition called proctalgia fugax. Proctalgia fugax. Now these are the only clinical features. These are the only clinical features, right? Which of the following is not true about hemorrhoids? Which of the following is not true about hemorrhoids? Copy किया हुआ क्वेश्चन. किसी और इंस्टीट्यूट से नहीं, किसी बुक से. Hemorrhoids are formed by expansion of endoanal cushions. Correct. Portal hypertension may result in hemorrhoid. Tell me, is it correct or not? It is not correct. It is not correct. It may cause rectal varices, but it will not cause hemorrhoid. It will not cause hemorrhoids. It will not cause hemorrhoid. And rest of them are correct. Rest of them are correct. Fine. Portal hypertension will cause rectal varices. बेसिक सा क्वेश्चन है बिल्कुल, लेकिन कई बार बेसिक से क्वेश्चन में ही चाबी अड़ जाती. 69-year-old, age is the first cue. 2-month history of pain. Feels full after eating small amount of food and has lost weight. Second cue. General physical examination is unremarkable. Remember, duodenal ulcer. Patient will experience weight gain, no weight loss, because patient gets relief after eating food. Relief. after eating food. Now, it could be gastric cancer, it could be gastric ulcer. Fine. Now, see here, patient feels full. Now, let's say I'm going to draw a patient of gastric ulcer. See, in gastric ulcer, capacity of the stomach is normal. I'm going to draw gastric cancer. What type of gastric cancer? Leather bottle stomach. So you see, if your patient has stomach cancer, capacity of the stomach is reduced, so your patient will have early satiety. Your patient will have early satiety. So your patient is having gastric cancer. Gastric cancer. Fine. Now, Menterier disease, your patient will present with protein loss enteropathy, protein loss enteropathy. So your patient is having linitis plastica, the leather bottle stomach, right? 50-year-old man, 2-day history of difficulty breathing, fever, rigor, and chills. Okay. Upper abdominal and shoulder tip pain on the right side. Doctor Sahab, diverticular disease will present on the left side. Shoulder tip pain on the right side. Wherever you see shoulder tip pain on the right side, always think about subphrenic abscess. He underwent laparotomy 2 weeks ago following a perforated appendix. That's a classical history of subphrenic abscess. Remember, if your patient will have appendix abscess, pain will be present in the right iliac fossa. Pain will be present in the right iliac fossa. Fine. Right iliac fossa. Now, this patient, cholecystitis can be plus minus, but remember, cholecystitis is more common in females. Fine. Secondly, okay, diverticular abscess, remember it is common on left side. So subphrenic abscess will tick all the right boxes. So we'll go in for subphrenic abscess. 23-year-old girl, young, attending a college party, was escorted into hospital by her friends. ना, जल्दबाजी में कभी आंसर नहीं देना. जल्दबाजी में क्लिनिकल सिनेरियो बेस्ड क्वेश्चन में जल्दबाजी में कभी भी आंसर नहीं देना. Read the question. By her friends after vomiting large amount of fresh blood, normally fit and well. That means she has no cirrhosis. So it could not be esophageal varices. Badly drinking about alcohol. Which of the following is the most likely cause? Fine. So here, she would have chest pain. She would have vomiting. She would have subcutaneous emphysema. What do we call? We call it macular triad. So not the right answer. Hemopsis. She would be bleeding very small amount of blood. And it would be unrelated to alcohol. So this will fit the right boxes. Mallory West tear. Mallory West tear is seen in esophagus and stomach. Bleeding commonly occurs from the branches of left gastric artery, and short gastric artery. Treatment is conservative. That means you just do decompression of the stomach and your patient would be fine. Exactly. Esophageal varices will occur in the setting of cirrhosis. Your patient doesn't have cirrhosis. 62-year-old female presents with 2-day history of left-sided pain and fever. She has localized tenderness, rigidity in the left iliac fossa. Blood tests revealed raised white blood cell count. TLC is high. C-reactive protein is high. Pain in the left iliac fossa. So, your patient is having diverticulitis. Definitely your patient is having diverticulitis. Right? Mother brings 5 weeks old son for pediatric outpatient clinic. She is concerned that he has been having forceful vomiting after feeds. Vomiting. Always hungry. Child is dehydrated, lethargic, smooth, firm, non-tender mass. What is this? Abdominal olive. Na, Dr. Saab, ORS nahi dena. So, your patient is having infantile hypertrophic pyloric stenosis. Remember, it is not present at birth. Most commonly, it will present at 2 to 3 weeks of life. Your patient will have projectile non-bilious vomiting. Now, because your patient is continuously vomiting, your patient will develop a special problem. Hypocalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Right? Now, that can be corrected with Ringer lactate. Fine. That can be corrected with 0.45% saline plus potassium. 0.45% saline plus potassium. Because Ringer lactate has potassium, we will prefer Ringer lactate as the answer. We will prefer Ringer lactate as the answer because it has got potassium. Yes, Dr. Saab, yes. Because we want to correct hypokalemia. अगर इसमें साथ में potassium लिखा होता, so we would have chosen this answer definitely. But because potassium is not mentioned, we'll select fourth option, Ringer lactate as the answer. Yes, dextrose also. Yes, dextrose also. So the correct treatment is half strength normal saline plus potassium plus dextrose. But because that is not there, we'll go in for fourth option, that is Ringer lactate. Buddy, if you see these options, fourth is the better answer. But the actual answer is third one, 0.45% saline plus potassium plus dextrose. Right? But among the given option, we'll prefer the fourth one. Yeah, 5%. Very quickly, what will you get to see on X-ray? You will get to see caterpillar sign. What do we get to see on barium? We get to see mushroom sign. What is the investigation of choice? Ultrasound. Right? डॉक्टर साहब बी एंड डी में क्या था? बी diverticular disease. That means there are some symptoms but no infection, no inflammation. Diverticulosis, that means there are no symptoms. So your patient has symptoms plus inflammation. So this is diverticulitis. 52-year-old chronic alcoholic vomiting fresh blood since early that morning. Now, this patient is more likely to have cirrhosis because he has been drinking alcohol for too long. So here the answer would be esophageal varices. Here the answer would be esophageal varices. Right? "40-year-old male prisoner, illegal migrant, presents to the prison's medical officer complaining of increased difficulty in swallowing. Confides in the doctor that he has been stuck in Mexico for around a year before crossing the wall illegally." 1 साल तक बेचारा मैक्सिको में फंसा रहा. Boiled rice and fish to eat. Otherwise well and denies the symptom. हाँ जी डॉक्टर साहब. अरे प्लमर विंसन सिंड्रोम का मैक्सिको से क्या लेना देना? प्लमर विंसन सिंड्रोम का मैक्सिको से क्या लेना देना डॉक्टर साहब? Your patient is having secondary eclasia. Remember, Chagas disease is the cause of secondary eclasia, endemic in Mexico. Endemic in Mexico. Right? Gastroesophageal reflux disease, no. Gastroesophageal reflux disease will not cause dysphagia, it will cause retrosternal pain. It will cause retrosternal pain. Fine. 42-year-old railway station announcement clerk. So that means habit of speaking loudly. Presents to surgical OPD with complaint of dysphagia, both solids and liquids. He is maintaining normal weight. See, one is your patient can have eclasia because the common age is 20 to 40 years. Your patient will have dysphagia, weight loss, and regurgitation. Second is your patient can have Zenker's diverticulum. Now here also your patient will have dysphagia, your patient will have regurgitation, your patient will have halitosis. Now, how to settle barium swallow? Barium swallow. Remember, endoscopy is considered dangerous. Endoscopy is considered dangerous in Zenker diverticulum. Esophageal manometry is an invasive investigation. Urea breath test is for H. pylori, totally unrelated. So we'll prefer barium swallow. Barium swallow, if it is eclasia, will give rise to bird beak called as pencil tip appearance. Called as pencil tip appearance called as rat tail appearance. Called as rat tail appearance. So barium swallow is the right answer. 65-year-old male presents with complaint of pain, epigastrium and weakness. Pain subside with antacid but reappears later, which revealed patient having microcytic hypochromic anemia. That means there was some bleeding. No long-term relief. What is the appropriate next investigation? Dr. Manisha Bete, rat tail filling defect is seen in carcinoma. Rat tail appearance is seen in achalasia. Rat tail filling defect in cancer, rat tail appearance in achalasia. So your patient has a peptic ulcer. The diagnosis can be confirmed by endoscopy. Can be confirmed by endoscopy. Why peptic ulcer? Because your patient has anemia most likely caused by continuous bleeding, right? For the patient in above mentioned question, as and when endoscopy was done, it showed ulcerated 3 centimeter lesion with irregular border, about 5 centimeter distal to the gastroesophageal junction. What is to be done now? Because this is an irregular border ulcer, there are chances of malignancy. So we will do the biopsy. We will now do the biopsy. Dr. Chaudhary, अगर सपोज, आई होप यू गाइज डोंट माइंड मी कॉलिंग यू बाय योर नेम्स, आप लोग तकरीबन आधी उम्र के होंगे मेरे से. So oral sucralfate will be given in benign ulcer, but यहाँ पे there are irregular borders, so there are chances of malignancy. So that is why we'll prefer doing the biopsy. We prefer doing the biopsy, right? Regarding GIST, gastrointestinal stromal tumors, most common clinical feature is bleeding. Endoscopy should not be done because remember the tumor will not be visible on endoscopy. Tumor is indolent, means it is slow growing. It is slow growing. Tumor is slow growing. Fine. Most of the GIST are usually solitary. Most of the GIST are usually solitary. So this is the correct option. Tumor, we may call it as aggressive, but you know, it does not spread. Normally it does not spread far. It does not spread too far. It follows an indolent course, slow growing kinds. Most common clinical feature of the following condition is what is this? Watermelon stomach. Watermelon stomach. So watermelon stomach will present with melena. Will present with melena. Watermelon stomach will present with melena. Remember, if the problem is here, this would be watermelon stomach. If the problem is here, this would be diula foy lesion. Here the clinical feature would be hematemesis. Here the clinical feature would be melena. Clinical feature would be melena, right? Watermelon stomach. 7-year-old child present with history of progressive right lower quadrant pain and vomiting. Diagnosis of appendicitis was made and patient operated. Intraoperatively normal appendix मिल गया. Immediately adjacent to appendix, multiple large lymph nodes in the mesentery and terminal ileum was found. The tissue appeared boggy. Boggy means swollen. and indurated, most likely diagnosis is mesenteric lymphadenitis. Mesenteric lymphadenitis. Remember, intestinal intussusception will cause intestinal obstruction and not pain. Fine. Acute lymphoma is very rare. Subclinical appendicitis is not, because the appendix is normal and there is nothing called subclinical appendicitis. There is nothing called subclinical appendicitis. So answer, correct answer is C. डॉक्टर नेस्कैफे जी, हम सारी ऑप्शन देखते हैं. यू आर अंडरस्टैंड, यू आर कंफर्टेबल इन हिंदी. एक्यूट लिम्फोमा इज वेरी वेरी रेयर इन एब्डोमेन, छोड़ दिया. इंटुससेप्शन में आपके पेशेंट को इंटेस्टाइनल ऑब्स्ट्रक्शन होगा. याद कीजिए, इंटुससेप्शन, कॉलिकी पेन, वैसा कुछ नहीं है आपके पेशेंट को. फाइन. प्रोग्रेसिव, लगातार बढ़ती हुई पेन. कॉलिकी पेन इज कभी हुई कभी कम, कभी हुई कभी कम. ये होता है इंटरसेप्शन में, लेकिन यहां पे ऐसा कुछ नहीं है. और चौथी ऑप्शन, सब क्लिनिकल अपेंडिसाइटिस. आपके क्वेश्चन की स्टेटमेंट में देखो, क्लियरली लिखा है दैट अपेंडिक्स वाज फाउंड टू बी नॉर्मल. डॉक्टर नेस्कैफे जी, सही नाम तो बता दो अपना, इफ यू आर कंफर्टेबल. चलो कोई नहीं नाम बताना तो इसका आंसर ही बता दो. So what it is? Fogarty balloon catheter. Fogarty balloon catheter. It is used for removing embolus from the bleeding vessel. Used for removing embolus from the bleeding vessels. Fogarty balloon catheter. 72-year-old man. Tender cord-like structure. Entire left lower limb present since several weeks. He was investigated for abdominal and back pain, weight loss. So pain and weight loss, 72 years age. Ultrasound and CT scan were done. They were able to clinch the diagnosis. क्या diagnosis था? I'll tell you the diagnosis. The patient had carcinoma pancreas. Superficial thrombophlebitis. Remember, carcinoma pancreas will have Trochio syndrome. So Trochio syndrome is migratory thrombophlebitis. Don't ever confuse this with the Trochio sign. What is Trochio sign? Trochio sign is carpopedal spasm. Remember, trozier node is supraclavicular lymph node, that is Virchow's node. Virchow's node. So your patient will have superficial thrombophlebitis, which is a common clinical feature of carcinoma pancreas. Carcinoma pancreas. Now deep vein thrombosis will present with pain, will present with swelling. Axillary vein thrombosis will be present in upper limb. Lippal Tranulois syndrome will present with multiple arteriovenous malformation. So answer is superficial thrombophlebitis. ये क्वेश्चन छोड़ते हैं, चोरी का है क्वेश्चन. 30-year-old woman has a history of recurrent attacks of fever, right upper quadrant pain, and jaundice with itching. That means your patient has obstructive jaundice. चोरी का क्वेश्चन मतलब किसी बुक से चोरी किया हुआ. Obstructive nature of jaundice. CT scan was performed which shows, देखो भाई अब इसमें तो कुछ भी नहीं है. Intrahepatic ductal dilatation with stones. Intrahepatic ductal dilatation with stones. Now, remember you have studied about Caroli disease. Caroli disease. You have studied about choledochal cyst. Choledochal cyst. Remember what was there in 4A, what was there in 4B. Fine. And what was there in 5. So remember it was multiple intrahepatic cyst, multiple intrahepatic cyst, multiple extrahepatic, and multiple extra and intrahepatic both. So the only treatment of multiple choledochal cyst is liver transplant, is for liver transplant. Liver transplant. डॉक्टर साहब आप जो ERCP बोल रहे हैं, ERCP is for choledocholithiasis. Choledocholithiasis will affect the extrahepatic duct. यहां पे stones कहां पे हैं? Intrahepatic duct. So your patient is suffering from choledochal cyst, not choledocholithiasis. Stones नहीं है, dilatation है. Choledochal cyst. Your patient is having multiple intrahepatic choledochal cyst. Multiple intrahepatic choledochal cyst. Only treatment is liver transplant. Only treatment is liver transplant. ओपन सर्जरी कर सकते हैं, बिल्कुल कर सकते हैं. 45-year-old women presents with right upper quadrant pain. अल्ट्रासाउंड कराया, कुछ फायदा नहीं हुआ. Solid lesion. Now this again is a very typical finding. CCT shows a vascular lesion surrounding a solid mass with central scarring. जो लोग एक बार पढ़ चुके हिपैटोबिलिरी धड़क से आंसर दे सकते हैं इसका. If you see central scarring on CT scan, if you see central scarring on CT scan, what is the diagnosis? Focal nodular hyperplasia. Focal nodular hyperplasia, the treatment is observation. No potential for malignancy. It has no potential for malignancy. No potential for malignancy. So you will just do the observation. Just do the observation. No potential for malignancy. Hepatic lobectomy and all, resection you will do with cancer. Enucleation you do for hemangioma, which is more than 7 centimeter size. Third and fourth option you do for malignant tumors. You do for malignant tumors. Doctor Sahab, why do you want to remove it? Focal nodular hyperplasia. No potential for malignancy at all. Why do you want to give the trauma of surgery to the patient? भाई सर्जरी करना कौन सा आसान है? चलो आपके लिए आसान होगा, मरीज के लिए अपना पेट कटवाना इजी थोड़ी ना है. थैंक यू बड़ी, थैंक यू. मैं तो पढ़ाता हूं, तुम लोग आते ही नहीं हो. 35-year-old women using contraceptive pills, oral contraceptive pill intake, right upper quadrant aching pain. Ultrasound of the liver shows single well demarcated hyperechoic mass, vascular solid tumor. Fine. So if you see any vascular tumor in the liver, there are chances that it is an hepatic adenoma. This is so vascular tumor that it is considered most common cause. It is considered most common cause of spontaneous hemoperitoneum. Spontaneous hemoperitoneum. Now, if it is more than 2 centimeter in size, then the treatment is resection. But if it is less than 2 centimeter in size, treatment is stop the oral contraceptive pills and observe the patient. Stop the oral contraceptive pills and observe the patient. It is common in females. It is common with the oral contraceptive pills intake. जो लोग क्लास में पढ़े याद करो, 4 फोटोएं दिखाई थी जो यहां नहीं दिखा सकते, तो वही 4 फोटो से याद हो जाएगा. Middle aged man suffering from hepatitis C undergoes liver biopsy. Liver biopsy. About 6 weeks later, he complains of pain. He complains of jaundice. Now, hemoglobin level is low. That means there is continuous bleeding. Fecal occult blood test was found to be positive. What it is? आदर्श पांडे जी, आई एम रियली सॉरी, मैंने सुना नहीं. आदर्श साहब एक बार दोबारा बोलेंगे प्लीज. डॉक्टर आदर्श पांडे जी, आपने क्या कहा जो हमने मिस कर दिया? वो अच्छा अच्छा, ठीक है डॉक्टर साहब, I'll do it. I'm really sorry to have missed your query. I'll do it. So the problem occurred after intervention. That means the problem is iatrogenic. Your patient has melena. Your patient has pain. Fine. Your patient has jaundice. Triad of Sandlom. It is seen in hemophilia. Triad of Sandlom. It is seen in hemophilia. Thank you, buddy. Thank you. It is seen in hemophilia. Fine. Pain, gastrointestinal bleeding, and jaundice. Triad of Sandlom. Hemophilia. Typical. 40-year-old blunt trauma presents with pain and jaundice. Stool test for guaiac. Guaiac means you are checking fecal occult blood. Which one of the following studies would be most useful? Again, buddies, your patient has pain plus jaundice plus gastrointestinal bleeding. That means hemophilia, blood in the bile. Where is the bleeding coming from? You will get to know by angiography. Right, G? 40-year-old female, alcoholic, being evaluated for a hepatic mass. Percutaneous ultrasound guided liver biopsy is contraindicated in which of the following? Hepatic adenoma. Remember, it is extremely vascular tumor. This can be considered a second choice. Fine. But hepatic adenoma is extremely vascular tumor. 40-year-old women suffering from I understand कि थोड़ा सा टाइम ज्यादा ले लिया आपका, बस 2-3 मिनट और घड़ी के हिसाब से. chronic cholecystitis, complains of right upper quadrant discomfort. On examination, the attended doctor found that patient has smooth globular mass in the right upper quadrant, moving with respiration and slightly tender. Remember, gallbladder secretes 20 ml of mucus per day. So this patient is having mucocele. Fine. Acute cholecystitis. Pain would have been worse. Your patient would have fever. Your patient would have high TLC. Murphy sign would be positive. In both first and second option. Empyema of the gallbladder. Your patient would have been very toxic. Heart rate, respiratory rate, both would have been very, very high. Right? So A and B are same, will present with same clinical feature. Severe pain would be there, fever would be there, TLC would be high, and Murphy sign would be positive. Murphy sign is inspiratory arrest. So mucocele. 52-year-old woman suffered from acute cholecystitis. She was advised laparoscopic cholecystectomy. However, she refused. मैं सर्जरी नहीं कराऊंगी. And she left against medical advice. 2 दिन बाद वापस आना पड़ गया. Increasing right upper quadrant pain, swinging pyrexia, high grade fever, extreme tenderness, leukocytosis, raised inflammatory marker, thick gallbladder wall, enveloped by omentum, pericholecystic fluid. Now give the answer. क्या बात, बड़े खतरनाक नाम रखते हैं आप लोग. मेरी कहानी मेरी जुबानी. बेटे अपना सही नाम बताओगे मन करे तो. देखो डॉक्टर साहब कर तो दिया आपके सामने. दिस पेशेंट इज हैविंग एम्पाइमा. Empyema means pus. If you see swinging pyrexia, high grade fever, if you see extreme tenderness, if you just see Murphy sign, some tenderness, it would be acute cholecystitis. If you see extreme tenderness, high grade fever, then it would be empyema. Empyema means there is pus in the gallbladder. इसमें डॉक्टर साहब देखो मैं वही तो बताया, रेकरेंट राइट अपर क्वाड्रेंट पेन. देखो इसमें इन्होंने पेन का जिक्र ही नहीं किया. इट इज नॉट पेन, रादर देन पेन दे हैव रिटन डिस्कंफर्ट. फाइन. सो यहां पे देयर वुड बी पेन, यहां पे देयर वुड बी पेन. इन म्यूकोसील there would be just discomfort or low grade pain. "76-year-old women, intermittent generalized abdominal pain, distension, vomiting. Her condition deteriorated." So if you see correctly, your patient has intestinal obstruction. She has been admitted as surgical emergency. On examination, she is grossly dehydrated. Abdominal examination shows generalized distension and tenderness. Acute cholecystitis will not cause intestinal obstruction. Cholecystoenterous fistula will cause, and it will give rise to gallstone ileus. What do you see? You see regular triad. ectopic gallstone. You see an ectopic stone. Fine. Then you see air in the biliary tree. We call it pneumobilia. And then you see intestinal obstruction. Liver abscess, there will be no intestinal obstruction. Empyema, there will be no intestinal obstruction. So in all other options, there will be no intestinal obstruction. Only in the second option, there will be intestinal obstruction. There will be intestinal obstruction. Yes, 60-year-old man underwent laparoscopic cholecystectomy about a year ago. एक साल हो गया. Remained well. Now he has developed colicky upper abdominal pain radiating to the back. Viral hepatitis. Pain is diffuse. Pain is dull. Stricture of the gallbladder. First of all, it will appear early. And generally, the pain is not colicky. Generally, the pain is not colicky. Jaundice is there. So your patient will have cholelithiasis. Your patient will have cholelithiasis. Here also colicky pain will not be there. Last question. 1 week old infant is brought to the hospital because of non-bilious vomiting. Upper GI discomfort can be considered as pain, but it can be considered as very dull, low-grade pain. For example, sitting for 2.5 hours, I'm having some discomfort near my ischial tuberosity. You cannot call it pain. An upper GI contrast study reveals duodenal obstruction. डॉक्टर नाग, आपने 3 तो नाम रखे हुए हैं जी, क्लर्क जी, नागार्जुन जी, जानकी जी, मुरलीधर जी. पहले तो अपना नाम बताइए और फिर डाउट बताइए. Annular pancreas is found. Which of the following statement about annular pancreas is true? This is the only correct option. Resection is not the treatment. Remember, the treatment is duodenostomy. Treatment is duodenostomy. Symptoms usually begin with vomiting, abnormal rotation encircling the second part. Remember, vomiting is bile stained since birth. It would be duodenal atresia. Vomiting, non-bilious since birth. It would be annular pancreas. Vomiting, non-bilious, starting at 2 to 3 weeks. It would be infantile hypertrophic pyloric stenosis. I'm really sorry, डॉक्टर मुरलीधर जी, आपने वो 2-3 नाम लिखे हुए थे ना, तो इसलिए. अब आप मुझे बताएंगे प्लीज, आपका डाउट क्या था? What was your doubt? Can you please tell about the question? Yes, I'll share. Now, can you repeat the question, Dr. Muralidhar ji? अरे हम लोग हंसते खेलते आपके साथ बातें करते हैं, आप बुरा मत माना करो प्लीज. वैसे लगी पड़ी है जिंदगी की इतनी, थोड़ा बहुत हंस खेल लिया तो उसमें गुस्सा मत किया करो. आदर्श पांडे जी का क्वेश्चन, that how to differentiate between second degree superficial, second degree deep, and third degree burns. Second degree superficial, papillary dermis burned. Second degree deep, papillary plus reticular, not full thickness. Papillary dermis, reticular dermis, subcutaneous tissue. Subcutaneous tissue is burnt, third degree burn. Fine. Now pain decreases. Pain is too much. Pain is little less. Third degree, no pain. Thin wall blister. Thick wall blister. No blister. All sensation intact. Only pinprick intact. All sensations gone. All sensations gone. Healing less than 2 weeks. Minimal or no scarring. 4 to 6 weeks with scarring. No spontaneous healing. Now, typical feature is burnt veins. Typical feature, burnt veins are visible. Now, these burns are dry, leather-like. Dry, leather-like. Dr. Clark-ji, empyema. See, empyema means there is pus inside the body. Pus inside the body will give rise to high-grade fever, will give rise to extreme tenderness. The heart rate would be high. Respiratory rate would be high. Total leukocyte count would be very high. There would be decreased urine output if the patient is advancing into septic shock. Right, G? So kindly allow me to end the class and then I'll share the PDF today. I'll share the PDF today. Right? Thank you. I'm always glad to be with you. बड़ी संदीप जी आज पक्का दोनों पीडीएफ्स को कंबाइन करके भेज दूंगा जी मैं. हाँ बंद कर दीजिए. अभी कोई क्वेरी तो अगर होता तो अभी तक आ गया होता.